Hello, everyone. Welcome to this session. I think in the interest of time, we're going to get started. So first, so this session, just make sure you are at the right session. It's effectiveness of anticoagulant therapy. We have great presentations lined up and in different populations. I think you're going to find this really interesting. My name is Xiaojun Li. I'm at Harvard Medical School.
My name is Yahui Yu. I'm at Georgia State University.
Yeah, we're co-moderators of this session. So as you may already be familiar with the setup, we're going to have the presentations. So we include 10-minute presentation and Q&A session. We actually have a slot. One of the presenters cannot be here today, so we're going to have a 15-minute slot after the third presentation. So if you have more questions for the first three presentations, that we can exhibit for that, but we'll still be able to take a few questions after each presentation. So with that, I'm going to get started.
So our first presentation presenter is Xinyi Huang. So let's welcome her.
So I'm going to use this. Yes. Thank you. Hi, good afternoon, and thank you for the moderator's introduction. So I am Xinyi Huang from National Taiwan University, and I'm now a postdoctoral research fellow. So in this part of my presentation, I'm going to introduce our study regarding the effectiveness and safety of clopidogrel versus aspirin in an East Asian population. This study was funded by Taipei Medical University affiliated Shuanghe Hospital, and the authors do not have any conflict of interest to the content of the study. Aspirin and clopidogrel are both guidelines recommended antiplatelets that can be used to prevent secondary stroke. However, clopidogrel is a prodrug. It should be activated first by CYP2C19 before platelet inhibitions. Therefore, if the patients were CYP2C19 pro-metabolizers, the effectiveness of the clopidogrel could be decreased. And therefore, a previous study have found that the Asian population might have a higher prevalence of CYP2C19 pro-metabolizers. Therefore, there are concerns about the decreased effectiveness of clopidogrel uses in Asian patients, and whether the clopidogrel use in Asian population would be better than aspirin is still not fully understood. So the objective of the study is to compare the effectiveness and safety of clopidogrel versus aspirin use in an East Asian population following acute ischemic stroke. This study uses the data from the full population data of the Health and Welfare Database in Taiwan. This is an administrative claims data from the National Health Insurance Program, which enrolled over 23 million enrollees with about 99.9% of the population in Taiwan. And the data from 2008 to 2018 was served as the data source. This was a retrospective cohort study with a new user design. We included patients with the first acute ischemic stroke admission between the 2009 to 2018 and were discharged with monotherapy clopidogrel or aspirin. The patients that prescribed with clopidogrel were in the exposure group, and the patients that prescribed with aspirin were in the reference group. The first acute ischemic stroke admission was defined as the index stroke admission period, and the discharge date of the index stroke admission period was defined as the index date. Each of the patients in the study was followed from the index date to the earliest occurrence of the following events, including the outcome of interest, switching to or adding on alternative antiplatelets, disruption in antiplatelet therapy, death, or until December 31st, 2018. Patients were excluded if they had a history of ischemic stroke at any period before index stroke admission, or if they were prescribed with clopidogrel or aspirin within 1 year prior to the index stroke admission, or if they had a diagnosis of atrial fibrillation or prescribed with oral anticoagulants within 1 year prior to the index date. Patients were also excluded if they were under 20 years old, switched between antiplatelets, prescribed other antiplatelets, or died during index stroke admission period. The effectiveness and safety outcomes were followed separately during the follow-up period. The effectiveness outcomes was the composite of major cardiovascular events, including the composites of acute ischemic stroke and acute myocardial infarction. And the safety outcomes was the composite of major bleeding events, including the composites of intracranial hemorrhage and major gastrointestinal bleeding. Social demographics and index stroke severity during the index stroke admission were adjusted as the baseline covariates. The comorbidities that happens within 1 year prior to the index date and the concomitant medications that prescribed within 90 days prior to the index date were also adjusted as the baseline covariates. This study applied the inverse probability of treatment weighting to balance the baseline covariates between the two study groups, and the absolute standardized mean differences less than 10% indicated that there were no significant differences in the baseline covariates between the two study groups. And we applied the Cox proportional hazard models to assess the time to event outcomes between the exposure and reference group. And additionally, we also performed sub-analysis for the patients with 20 to 79 years old patients. After inclusion and exclusion criteria, we identified about 71,000 of eligible ischemic stroke patients, with about 5,000 of clopidogrel users and about 65,000 of aspirin users. Before inverse probability of treatment weighting, clopidogrel users were found to be older, have more serious index stroke severity, had a longer length of hospital stay, had more comorbidities and concomitant medications uses compared to the aspirin users. And after inverse probability of treatment weighting, all baseline characteristics and the covariates were balanced between the two study groups. Regarding the effectiveness outcome, we found that there were no significant differences in the risk of composite major cardiovascular events, acute ischemic stroke, and acute myocardial infarction between the two study groups. And we also found that the results from the sub-analysis of the effectiveness outcome also were similar to the findings from the main analysis. Regarding the safety outcomes, we found that the clopidogrel users were associated with a lower risk of composite major bleeding events and also a lower risk of intracranial hemorrhage compared to the aspirin users. And again, the sub-analysis results in the safety outcomes were also similar to the results from the main analysis. Compared to the previous studies, this present study found that the clopidogrel users provide a similar effectiveness profile to the aspirin users, and this is consistent with the previous study's finding. And additionally, we also found that the clopidogrel users were associated with a lower major bleeding risk, especially the risk of intracranial hemorrhage, compared to the aspirin users. And this finding is new to the current evidence. We acknowledge that the study may have some limitations. First of all, because the study was conducted by using the administrative claims database in Taiwan, so we are not able to know the patient's lab data, image report, or the lifestyle management. So the residual unmeasured confounding could still exist. And the second is that we are not able to know the patient's compliance because the prescription filled was not equal to a prescription taken. And the last is that the CYP2C19 genetic testing cannot be assessed from the database we use for our study, so that we are not able to know if the patient is actually CYP2C19 pro-metabolizers or not. So the conclusion of the study is that the clopidogrel could be an effective and safe alternative to aspirin for secondary stroke prevention in an East Asian population. And the effectiveness of clopidogrel seems not to be altered in a population with a high proportion of CYP2C19 pro-metabolizers. Future study can directly link to the genetic data to confirm the results of our study. And before the end of my presentation, I would like to take a moment to thank to the co-authors of this study, Professor Zhizhen Wang from National Taiwan University and Professor Zhongshuan Wu from Taipei Medical University. And they are both mentors during the period I pursued my master and PhD degree, and I'm really grateful for their unconditional support throughout my research work. And I would also like to thank to the Health and Welfare Data Science Center of the Department of Statistics in Taiwan. So this is the end of my presentation. Thank you so much for listening.
Thanks for the presentation. We now have some time for questions. So if you have a question, please come to the microphone in the front of the room.
Yes, I'm Edward from the Division of Pharmacoepidemiology in Boston. First of all, beautiful slides, beautiful presentation. I was wondering, how did you account for the weighting with estimating the standard errors? Maybe I may have missed it, but did you use, for example, the bootstrap or robust variance estimator?
Yes, bootstrapped.
Okay, thank you.
Thank you.
Hi, I'm Omar, and I'm Edward's colleague. I have just a question. Since you didn't have genetic data, could you have used another variable or a proxy to kind of try to estimate whether people have, the specific variant or something like that in the data?
Yeah, thank you for your questions. This is actually a very important question that we discuss in our team a lot because we are not able to link to the genetic data, so we are not able to know the patient's the CYP2C19's condition. So, but however, we do not have any surrogate variable to this. But in the future, we are planning to link to the genetic data, which is available very recently in Taiwan. So maybe we can directly link to it and further to know whether these results will be affected by the CYP2C19 pro-metabolizers patients. Yeah, thank you.
I think we still have time for one more question.
Maybe I'll ask one question in case I'm not taking others. But I might have missed this. How was death handled in the analysis?
Yeah, thank you. So, because this is a great question, during the point we analyzed this study, we want to analyze the death causes and the death patients. But because in that point we didn't link to the death data file in our data, we didn't bought that data file, so we cannot access the death patients. So we exclude so we did not. We see the outcomes only for the patients who happens the major cardiovascular events and also the safety events, but we cannot know if the patient is actually death during the point, but we can know if the patients withdraw from the insurance. So because in the Taiwan, we continuous enroll in the insurance data unless this patient is dead or they went abroad to another country. So if this patient is not went abroad to another country, we consider it is a death patient. Yes, so we censor the patients during the follow-up period. Yes.
Okay. Was it handled in a computer risk analysis at all, or no?
Because we are not able to, at that point, we are not able to know the death data. But actually, in the sequential analysis afterward, we did another analysis that included that data. But that data is already published last year in the Mayo Clinic proceedings, so I did not present it today. Yes.
Okay, great. Thank you. That's a great presentation.
Thank you.
Thanks.
Thank you so much.
Okay, next we have Edward Fu from Harvard Medical School.
actually 2 versions of my presentation in this folder. So let's see which one I need to select. They also have exactly the same file size, so let's try the first one. Okay, so good afternoon, everybody, and thank you for the opportunity to present this work jointly with these people from the Division of Pharmacoepidemiology at Brigham and Women's Hospital. I'm Edward Fu, I'm a postdoc at the division, and I'm happy to tell you something about a project we did about the comparative safety and effectiveness of warfarin or rivaroxaban versus apixaban in patients with advanced CKD and atrial fibrillation. Here are our disclosures, and received some funding from NIH and from Dutch research organization. So atrial fibrillation is really highly prevalent in patients with advanced CKD, with prevalence estimates up to 20%. And CKD is also an important risk factor, especially advanced CKD, which is when the kidney function drops below 30%. It increases the risk for major bleeding 7-fold, and also the risk of thromboembolism like stroke. Unfortunately, there's very little evidence to guide anticoagulant treatment in this patient population, and the reason for that is that the landmark RCTs that investigated the direct oral anticoagulants really excluded patients with creatinine clearance, so kidney function, less than 25 milliliters per minute. And the second reason is that no RCTs have been performed that directly compare head-to-head the different DOACs. So the aim of this study was to investigate both the safety and the effectiveness of rivaroxaban or warfarin versus apixaban in this non-dialysis CKD stage 4 to 5 population with routine healthcare data. So we used 2 large US health insurance databases, Optum, the identified Clinformatics Datamart database, which contains a nationally insured US population. And the second database we used was Medicare, which includes US residents older than 65 or those less than 65 with disabilities. And these claims-based databases contain longitudinal individual level information on healthcare use in an outpatient diagnosis, diagnostic tests and procedures, and also pharmacy dispensing of drugs. So this is the design diagram showing the look-back periods for the inclusion and exclusion criteria. So we identified patients who newly initiated warfarin versus apixaban, which constitutes cohort 1, or rivaroxaban versus apixaban, which constitutes cohort 2, and initiation of treatment serves as start of follow-up like time 0. We included patients who had a diagnosis of atrial fibrillation or flutter and at least 1 year of continuous enrollment in these databases to ensure that we can capture their comorbid conditions. And they also needed to have 2 diagnoses, 2 diagnosis codes for CKD stage 4 to 5. We excluded patients less than 18 years in Optum and less than 65 in Medicare, and we also excluded patients with a history of pulmonary embolism, deep venous thrombosis, joint replacement, which could be indications for direct oral anticoagulants, as well as dialysis, hospice stay, and valvular heart disease. Of course, this was a new user active comparator cohort study, so we also excluded individuals who previously used any DOAC or warfarin. And lastly, we excluded patients who had a major bleeding event recently in the last 30 days. Then we followed patients from the first day after cohort entry until outcome occurrence or the end of study period, disenrollment, death, treatment discontinuation, or change to another treatment, another anticoagulant. These are the outcomes we looked at. Hospitalization with major bleeding, which included gastrointestinal or intracranial bleeding and ischemic stroke. And the definitions we used have been previously validated with a positive predictive value of 85 to 95%. And the definitions were based on ICD-9 or 10 diagnosis or procedure codes. So to adjust for baseline confounding, we used one-to-one propensity score matching and adjusted for 80 confounders, a wide range of confounders, including demographics, geographic region, calendar year, comorbid conditions, medication use, healthcare use, like number of hospitalizations or ED visits. Risk scores that are important, CHATS-VASC, HESBLAT, and the claims-based frailty index. To estimate hazard ratios and confidence intervals, we used goal-specific Cox regression, and we used a weighted Allen-Johansen estimator. We didn't use a weighted. We used the Allen-Johansen estimator to estimate cumulative incidence curves and to account for the competing risk of death, estimating the total effect of treatment, which can possibly be mediated by death. The effect measures were estimated separately in each database because we had two and then pooled with a random effects meta-analysis. So shown here are the baseline characteristics for the first cohort, apixaban versus warfarin after matching. A little bit more than 6,200 patients in each arm. And as you can see, it's quite an old cohort, 79 years, which you would expect for an advanced CKD population. And also with the Medicare database, 50% were women. And a large proportion of comorbid conditions, 66% ischemic heart disease, 50% heart failure, 65% diabetes, and also a large proportion used beta blockers, diuretics, statins, and renin-angiotensin system inhibitors. So shown here are the results for this cohort, warfarin versus apixaban. The hazard ratio we estimate was 1.85. And apixaban basically served as the reference group, so it means that the rate of major bleeding was higher for warfarin. You can also see the cumulative incidence curves, and we estimated a 5.1% higher absolute risk for the warfarin initiators compared with the apixaban initiators. These are the curves for ischemic stroke. The hazard ratio was 1.14, and as you can see, the confidence intervals are very broad since there were few ischemic stroke events. And the 2-year absolute risk difference was 0.1%. This is the second cohort, which compared apixaban versus rivaroxaban, which contained 2860 patients in each arm after matching. Mean age was 78 years. And similar to the other cohort, the proportion of comorbid conditions was pretty high. Again, more than 60% ischemic heart disease, 43% heart failure, 60% diabetes. When we compared rivaroxaban versus apixaban, we also saw that apixaban did better since the hazard ratio was 1.69 with a higher rate of major bleeding for rivaroxaban. And also at 2 years, the absolute risk difference was 3.5%. For stroke, we observed a hazard ratio of 0.71, but as you can see from the cumulative incidence curves and the confidence intervals, actually it was very uncertain. And the 2-year absolute risk difference was minus 0.7%. So, in conclusion, we found that in this nationwide US study of persons with CKD stage 4 to 5 and atrial fibrillation or flutter, both rivaroxaban and warfarin were associated with a higher risk of major bleeding than apixaban, which suggests a superior safety profile of apixaban. The results for ischemic stroke were more inconclusive due to few events and wide 95% confidence intervals. So there should be really additional studies to get more precise estimates for that. A couple of limitations to consider in this analysis. So residual confounding is an option always in observational studies. We did our best to adjust for a wide range of confounders. And one reassuring note is that the baseline characteristics, even before matching, were already very similar. We did not study the dabigatran or edoxaban in our analysis since few patients started these drugs. They are not commonly used in US practice. However, this should not affect really the implications of our findings as these drugs are not in routine use. We also lacked information on the quality of warfarin control, and this actually may explain the higher bleeding risk that we observe for warfarin versus apixaban. But on the other hand, it's one of the advantages of DOACs, which do not require routine coagulation monitoring. We also use diagnosis to ascertain CKD stages 4 to 5 instead of EGFR, which is preferred. We did a small internal validation study where we found that the positive predictive value of the CKD diagnosis codes was 75%, compared with using EGFR as the gold standard. And lastly, like I said on the previous slide, we had a low number of ischemic stroke events, and larger studies are needed for more precise estimates. So a couple of last comparisons with RCT data. Like I said, there are no head-to-head RCTs comparing different DOACs. But for apixaban versus warfarin, there's a small subgroup analysis of the Aristotle trial, 269 patients with a creatinine clearance between 25 and 30, where they found that apixaban had a lower rate than warfarin, which is consistent with our findings. And then this is my last slide. What could potentially explain these increased bleeding risks? For warfarin versus apixaban, we know that apixaban has a lower propensity for drug and food interactions. It's easier to use, does not require routine coagulation monitoring. And also in the advanced CKD population, there are greater fluctuations in INR. For rivaroxaban versus apixaban, there are some small trials that show that apixaban leads to lower anti-factor 10A peak levels, which may explain the lower bleeding risk. And apixaban also has lower renal clearance, which may be important in patients with advanced CKD. Thank you for your attention, and I'm happy to take on any questions.
Thank you. Doug Watson. In the symposium this morning on creating code lists, they talked about the need to validate codes within the specific database that you intend to do your research, because the results can vary from one database to the other. So I'm just curious whether the prior validation that you mentioned with your outcome codes had actually been done in these same databases, or were they done in a different setting?
Yes, it was based on data from Optum, where lab measurements are available in 45% of the sample. To improve sort of replication, we also published all the ICD codes in supplement for all the definitions. And lastly, we used, it's called ADION, a program to analyze data, which prevents making mistakes with coding, as it's very standardized.
Hi, John Connolly from Harvard Pilgrim Healthcare Institute. I was just curious if you could expand a little on why you chose to use matching, acknowledging versus like a weighting or something like that. Acknowledging, as you said, there's probably not a lot of confounding here in this particular comparison, but I know there's a lot of conversation about whether or not that's good or not. So just curious what your thoughts were.
Yeah, good question. We actually used propensity score overlap weighting in one of the sensitivity analyses, which I did not show, but it's in the paper. And it actually led to virtually identical results. Of course, if you think about it, if you use different matching or weighting methods, you look at a different estimate, right, a different population, at ATT or ATO overlap or average treatment effect among the treated. So it slightly changes the interpretation, but the numbers were virtually identical, the estimates.
Okay, thanks. Yep.
Thanks, Edward. And
Thank you.
if you have more questions, we have some time after the third presentation to take that. Thanks.
So our next presenter is Dongwan Yun.
Good afternoon. I'd like to express my gratitude to all of you for joining this seminar. My name is Dongwan Yun from Sangkyungan University in South Korea. The study title is Emulating Randomized Controlled Trials of Non-Vitamin K Antagonist Oral Anticoagulants in Patients with Venous Thromboembolism. Here is my disclosure, and this study is under first revision in the BMC Medicine Journal. and there is 2 independent integrities of source of funding, and there is no relationships to disclose. Let's move on to the background. Randomized control trials remain the gold standard for assessing the efficacy and safety of medical products for clinical and regulatory approval. The strict conditions required to demonstrate efficacy often limit the applicability of RCT result to routine clinical practice. To address this challenge, there is an increasing interest in the use of real-world evidence, such as non-interventional real-world data. However, concerns remain regarding the reliability and validity of effect estimates derived from real-world evidence studies. Meanwhile, the introduction of NOACs has dramatically shifted the therapeutic paradigm of VTE treatment. Here is a graphical depiction of an anticoagulant initiator in South Korea. NOAC accounted for about 80% in March 2019. However, a potential conflict of interest among trial sponsors may make it difficult to evaluate the comparative efficacy of different NOACs. So, in light of these shortcomings of RCT, RWE studies could serve as an alternatives to assess the treatment effect of NOACs in routine clinical practice. Therefore, given the possibility of utilizing RWE for regulatory decision-making, we aim to evaluate whether the findings from RWE studies can support regulatory decisions derived from RCTs of NOACs in patients with VTE. We used the HERA database from 2012 to 2020. All resident Korean national and foreign are covered by the health insurance system, and we include anonymized comprehensive longitudinal data on individual level demographics and healthcare-related service from inpatient, outpatient, and emergency department settings. And overall PPV for diagnostic records and claims data was 82% according to a previous validation study. And also, this database includes information of patient characteristics, diagnosis, and procedure, and prescription and service utilization information. We selected 5 RCTs, including Amplifier, Recover 2, Hokusai VTE, Einstein DVT, and PE, where phase 3 pivotal trials of NOACs in patients with VTE. We conducted an active comparator new user propensity score matched nationwide cohort study to emulate 5 pivotal NOAC trials in patients with VTE. And for each trial, 5 emulation cohorts were constructed separately, and each cohort comprised adult patients newly initiating treatment with individual NOAC or warfarin. And then we implemented the same pre-specified eligibility criteria that were utilized in the RCT as closely as possible. Here is a summary of the table that I emulated from RCT and RWE. In the NOACs randomized controlled trials, warfarin was used as the comparator and recurrent VTE was assessed. To ensure consistency, I have closely emulated exposure and outcome definitions from these trials in the emulation cohort. But as you see, comparator information about parenteral anticoagulant was not emulated in this study. In terms of outcome, the primary outcome was recurrent VTE, defined as a composite of deep vein thrombosis or pulmonary embolism, using ICD-10 diagnostic codes in the primary position of inpatient claims accompanying imaging procedures, such as Doppler ultrasonography, computer tomography scan, or venography. A previous validated algorithm that showed a positive predictive value of 83% was used. And then we assessed 69 potential confounders to adjust for underlying differences and to obtain comparability between the groups in the RWE study as a proxy for mimicking baseline randomization. And in terms of active cancer, it was defined as a first diagnosis of cancer with a unique domestic V code within the 6-month period prior to the index date. And the V code was attributed to patient with a cancer diagnosis that was confirmed by histopathological, cytological, radiological, and immunological findings. Considering the likelihood of lower treatment adherence in routine clinical practice, we adopted as treated approach. And then we conducted one-to-one PS matching and estimated incidence rate and hazard ratios using Cox proportional hazard models. Sensitivity analysis was conducted including intention to treat approach. After estimating effect estimated in RWE, we compared the findings between RCT and RWE using agreement metrics proposed by the RCT duplicate initiative, as you may know. Yeah. So regulatory agreement quantifies the extent to which the RWE study would suggest the same regulatory decisions as the trial, and was defined as whether the estimated effect in the RWE study did not exceed the pre-specified non-inferiority margin of the corresponding RCT. And then estimate agreement was defined as whether the RW estimate lay within the 95% CI of the RCT estimate. Last, standardized difference estimate the extent and direction of difference in findings between the RCT and the corresponding RW study. And here is a formula to calculate the standardized difference, and absolute standardized difference of higher than 1.996 regarded as a significant difference between RCT and RWE. Now moving on to result, here are baseline characteristics of between RCT and RWE studies. Despite applying the same eligibility criteria, the baseline characteristics of each trial and corresponding emulations were generally different. So as presented in this table, real-world populations were older and have more female and had a higher prevalence of active cancer. And then Asian fraction of all RCTs were relatively low, except for Hokusai-BT, which accounted for about 20%, but other RCTs showed about range from 6 to 8%, 6 to 12%. Here is the main findings of my study. Overall, the extent of agreement between RCTs and the corresponding RWE studies was best for regulatory agreement, which met 5 out of 5, and standardized difference met 3 out of 5, as opposed to estimate agreement, 2 out of 5. This is likely because RWE estimate showed a significantly lower risk of the recurrent BTE in each emulation than those of RCTs. So here you can see the lower risk of estimated in RWE compared to RCT. So we found that NOACs are not only non-inferior to warfarin therapy as proven in RCTs, but are likely superior. And based on the extent of agreement between RCTs and RWE studies, RA achieved for all 5 emulations, EA for 2 emulations, and SD for 3 emulations. Compared with other studies, compared to the result from the RCT initiative, RCT duplicate initiative, which was published in JAMA in this year. So our study presented very similar findings in terms of RA, but this was a little bit different from the definition of statistical significance of the previous study and standardized difference. However, in our study, we found different results for estimate agreement because the effect estimate were generally favorable for NOACs compared to the result of the RCT and the previous study. So here is a potential explanation about this result. So emulation difference in terms of estimate agreement may be partly explained by the differential treatment quality of the warfarin between RWE and RCT. As presented in this figure, East Asian has increased bleeding risk profiles compared to Caucasian. This phenomenon is so-called the East Asian paradox. So while the target INR of 2 to 3.0 has well been established in Caucasian population, Asian physicians conventionally tend to adhere about INR of 1.6 to 2.6 due to bleeding concerns. So resulting in a relatively lower mean in time in therapeutic range for warfarin in routine clinical practice compared to RCTs. So the lower TTR leading to higher BT recurrence in warfarin groups and resulting the lower HR in RW estimate. In conclusions, RW studies can deduce similar findings, similar conclusions in NOAC VT settings, suggesting the possible use of non-randomized RWE to complement RCTs for regulatory decision making. Further studies using other sources of real-world data and on different treatment would benefit regulatory authorities by increasing their confidence in the validity and reliability. Yeah. Thank you for your attention, and thanks to all members of my research group, Sangkyungan University, and pharmacoepidemiology and pharmacovigilance.
We now have some time for questions.
Hi, this is Xinyi Huang from National Taiwan University, and I'm curious about did your study actually measure the time to, in the therapeutic range, and can your database data source assess this kind of data of the INR, and did you set a range of it? Yes, thank you.
Unfortunately, we cannot access to the healthcare examination data. So we cannot access to the INR value, but previous studies suggest that INR therapeutic time in therapeutic range of about 30% was reported in South Korea and in multi-site studies. So in light of these findings from the previous reported TTR, so our findings can be partly explained by the factor of TTR, lower TTR in our population.
I also have one question.
Yep.
So as you mentioned in your presentation, the real-world population have different characteristics when compared to those included in the trial, such as age or prevalence of PE. Do you think some of this could be the reason why you see the effect was more favorable for NOACs in your study?
Yes, that's a very good question, and I was just wondering about the effect of these factors. But my own conclusion was that these all factors are affected as a combination. So the differential baseline characteristics and the differential treatment qualities and the emulation difference about definition of exposure and outcome definition. So these kind of factors can be affected our result. So I prepared some backup slide for about this. So yeah. In our study, sex, age, and the prevalence of active cancer was a little bit different. But so in terms of sex, given the higher risk of bleeding in women observed in prior meta-analysis, so the potential impact of sex difference in effect estimate cannot be ruled out. And for age, differential age is a prominent factor in VT incidence. And comparative efficacy of NOACs stratified by age showed a shift in trial estimate favoring NOACs in elderly. And for active cancer, one systematic review reported a trend in favor of NOACs for the efficacy outcome in patients with active cancer by showing preventive effect with NOACs compared to patients with non-active cancer.
So now we still have some time for questions until like 2:30. So we welcome like. Yeah,
together.
it's like we welcome all the questions for the presentation so far.
For those who just came in, our fourth presenter unfortunately could not be here today, so we have this extra time. So if you have any questions for the previous presentations, feel free to ask now, or we can just sit in awkward silence, or we can meditate together. If you have any questions. Or we can try to imagine what the fourth speaker was going to say. That you can do that as well.
I will try to break the silence. So the RC duplicate project was also a project done by my division, emulating 30 trials. This is more a question for the group, so please, if you want to discuss. So if I think about the goal is very important that we, want to see, can we get the same estimates with observational studies as RCTs, which is a very important question, right, to get confidence in our findings. Maybe the most important question that we are now facing with improved causal inference methods, target triangulation, improved data quality. But if you think about how many differences there are between the trial and if you're trying to emulate it with definitions of exposure, with definitions of confounders, comorbid conditions, there may be difference in estimates, right? What type of treatment strategies are you looking at? When do we censor patients, et cetera, how long are they treated? A difference in baseline characteristics. How much do we learn from these efforts if we, and this is not a critique on your study, which is very good, but just in general, I'm interested to know what you think about that.
First of all, our motivation to conduct this study was the result from the RCT duplicate initiative of your division. And I also so admired about the work of both RCT duplicate initiative. But the differential baseline characteristic would be occurred despite attempt to replicate the same eligibility criteria. But if we access to the individual patient level data of RCT, then we can weight the individuals and then have conduct some PS approach. Then we can estimate the more concise and adequate estimate that we can yield. But I think I agree about your concern about the differential baseline characteristic about it. But it would be a very important approach to assess about it, to address it about it.
Geeta Iyer, next presenter from Harvard Pilgrim Healthcare Institute. So I completely agree. I feel like because there's such a movement towards always kind of comparing what we are doing in observational data with an eye of what the RCT would look like versus what RCTs are already out there, even if you implement sometimes the exact criteria, just by the nature of who's there in the observational database, you're gonna have a different mix of people, right? Like even age groups sometimes are just so different simply because the trials kind of recruit a certain group of individuals versus in the observational data, it really depends on who actually goes to get healthcare more than anything else. So I think if we what I would feel like is the best benefit of looking to RCTs all the time to see is to make sure that we're not making any obvious missteps in designing the study, as well as in the analysis of the study, as well as trying to keep it as a benchmark, but not always with the eye of like, that number is what I want. It's more about, does observational data give us the results in the same direction, in a similar ballpark? Are there certain subgroups? Because I feel like observational data does have a lot to offer outside of just thinking about it in terms of a trial context, but also it serves as such a great opportunity to understand, why is it different? Are there certain subgroups that have never been included? Because oftentimes by kind of expanding our definition a little bit, we do get individuals who have not been included in the trial but have gotten the drug anyway. So I feel like there is a lot to be done, but if we keep trial as a benchmark in terms of design and analysis, I think we'll get a lot further than always aiming to kind of match that estimate, because sometimes we just can't do it simply because of, like you said, estimates are different, so many things are different. So that's what I think, yeah.
Hi, it's Xinyi again. And this question is another question is for both the previous presentations from the Edward and Dong Yang. And just like I'm very curious about these questions because I also conducted previously using the National Health Insurance Database to evaluate the effectiveness between the warfarin and the rivaroxaban and the dabigatran. And we concur a lot of problem about the severity of the bleeding, because this is what the editors and the reviewers will consistently ask us. How do you measure your severity of the bleeding by your database? And it is a very important question, because people can bleed very minor and bleed out very major. So I'm very curious. So in your setting, in your database, did you actually did something to measure the severity of bleeding, or just limitations? Yeah, thank you.
Yeah, in my study, yeah, that would be also a limitation of this study. So, yeah, the severity of major bleeding would be a very important factor in assessing the effectiveness or safety of in NOAC patient with BT or AFib. Yeah, but it cannot be easily measured unless the linkage between the health examination data. Yeah, but at this time point, it cannot be assessed using our country's data. Yeah, so it remains a limitation of this study.
So in our study, we actually looked at hospitalization with major bleeding, so really hospitalization. And what we did was, for example, also look at procedure codes associated with hospitalization, like if people need a blood transfusion. So we used that to ascertain whether it was a severe bleed or not. Hopefully the paper, we're now in second rounds of revisions. It will be published in the American Journal of Kidney Diseases, and the supplement contains all the code lists, so you could use that.
Okay, do you want to go back to your seat? You have been standing here for. I actually have a question for Edward, because we still have time. On one of your survival curve slides, I believe it's the third one, see major bleeding between rivaroxaban and apixaban. It looks like the survival curves were going to cross at the 2 years. I think it was ending at that point. Curves were basically merging together. I think so. I was wondering if you have done sensitivity analysis to extend the follow-up, and if you have actually looked at this proportional hazards assumption there.
It's a very interesting question. So one thing, maybe I can show it. so everybody knows what the chair means. So actually, at that point of follow-up, after 2 years, there are very few people left in the sample because the adherence in routine care in the US is pretty low. Most people stop within 4 to 6 months with their treatment, which is very sad. And an important point to improve adherence is adherence. Let me get up the curve. Do you mean this one? No, this one.
Yeah. This one.
So if you look at 24 months of follow-up, there are only 182 people left in the rivaroxaban group and only 300 people. So part of it may be, and the confidence intervals become very wide after that because there are so few people left. So part of it is a little bit chance, I think. There's, then about hazard ratios. So there has been written a lot about hazard ratios. Are they causal? You can read Miguel's papers and papers by others. That's why I always present absolute risks because they don't suffer from that inbuilt selection bias by conditioning, because the hazard is basically the risk conditional on having survived until a certain point, which may not be causal because you're not looking at groups that are similar anymore, right? After 1 year follow-up, you have sort of depletion of susceptible patients. And there's another paper by Miguel in JAMA about why test for proportional hazards, which beautifully explains why the proportional hazard assumption is never met, precisely because of the same reason. If a drug is beneficial, then if you look at the hazard ratios over time, the sample, the patients included in the sample, they will differ over time, so the hazard ratio will also differ over time. And the hazard ratio, the proportional hazard assumption will only be met if there is no causal effect of the treatment. So, include absolute risks in your papers, I would say.
Okay, great. I think we still have time for one more question. Yeah, please.
So I actually have a question for Dongwon. But so I saw your studies majoring as treated effects, and then when you compare it to the RCT, do they also major in the per protocol effect, and do they account for the impacts from post-randomization factors when they measure the per protocol effects?
Actually, I did intention to treat approach in sensitivity analysis. There was some variation in terms of agreement metrics, but the results were largely consistent with the main findings.
Just get started. Okay, I think we're going to move on to our next speaker, Geeta Iyer from Harvard Pilgrim Healthcare Institute.
Sorry about that. Hello, my name is Geeta Iyer. I'm happy to be presenting the work done by our team titled The Comparative Effectiveness and Safety of Warfarin, Rivaroxaban, and Apixaban in Patients with Venous Thromboembolism, an analysis of 3 real-world US healthcare databases. This work was funded by a PCORI award, and none of the authors have any relevant disclosures here. So because VTE already has been discussed a little, I'm going to go a little bit faster for this one. So as a background about venous thromboembolism, this disease includes both deep vein thrombosis and pulmonary embolism and affects approximately 500,000 people in the United States each year. Around 10 to 30% of these individuals experience a recurrent event in the first 6 months to a year respectively. These recurrent events are exacerbated in patients with older age, those who are males, as well as who have certain clinical conditions such as cancer or other relevant coagulopathies. We have many agencies that have proposed guidelines for the treatment of VTE, and one One of them, which is given by the American College of Chest Physicians, recommend that for VTE patients, they should be treated with oral anticoagulants at least for a minimum of 3 months, and any follow-up visits for certain individuals could be as long as indefinite therapy. So for several decades, warfarin was the only oral anticoagulant available, but in the last decade or so, we have had at least, I think around 5, there's another one after this, but we have 4 marketed in the US, which are approved for specifically secondary prevention of VTE recurrence. We have, most of the guidelines actually have adopted DOACs to be the first-line agents compared to warfarin, but if you look at all the oral anticoagulants together, there's not a lot of information about head-to-head comparisons between more than just a pairwise comparison to see which one is a more effective or a safe option. So to this end, the objective of our study was to compare the safety and effectiveness of 3 most commonly used oral anticoagulants, that is warfarin, apixaban, and rivaroxaban, using 3 US healthcare databases, which include both federally insured as well as commercially insured individuals. This was a new user parallel group retrospective cohort study. The 3 databases that we used were Medicare Fee-for-Service, which is the federally insured individuals, Optum's de-identified Clinformatics Data Mart, and IBM Market Scan. The later 2 include commercially insured individuals. These administrative insurance claims databases contain longitudinal de-identified administrative data for large geographically and clinically diverse populations. They contain information on enrollment information, demographics. We have information regarding encounters, both inpatient and outpatient, as well as in the emergency, and prescription claims. So in terms of the population that we included individuals who had an inpatient admission with a code for VTE. The code was ICD 9 or 10 in the primary position. This was considered the index event. If individuals had more than one such event, the first one was considered for our study. We included, specifically in terms of age, for the commercially insured, we included individuals more than 18 years of age, and for Medicare beneficiaries, we only included those above the age of 66. We imposed additional selection criteria in the 365 days before the index date, which was they should have continuous medical and pharmacy eligibility, no inpatient admission in the last year for VTE, or any oral or parenteral anticoagulant prescription during this time. We included individuals who had filled at least one of the 3 of our relevant oral anticoagulants within 30 days of discharge from the index event, and this was considered the index RX date or the time 0. We have 3 exposures of interest, as I mentioned: warfarin, rivaroxaban, and apixaban. Patients were assigned to the treatment based on what was the first initiated oral anticoagulant. And because we also looked at the on-treatment analysis, we assessed whether individuals were continuously exposed, and we assessed this using a minimum of a 14-day treatment gap between subsequent prescriptions. So that just means that if individuals fail to fill out the next prescription for the same anticoagulant within 14 days of the end of day supply of the previous one, we would consider them as being discontinued. The outcomes of interest were VTE recurrence, which was defined in the similar fashion as the index event itself, which was a new inpatient diagnosis code for DVT or PE in the primary position. Our safety outcome was hospitalization for major bleeding, which was defined as inpatient admission with a diagnosis code of intracranial bleed, gastrointestinal bleed, or any other major bleeding event. We also had a secondary definition for major bleeding, which has been proposed in 2011 and was validated by Cunningham. We updated that to include the ICD-10 codes as well. These are the covariates that we included in our analyses over the period of 365 days before the index date up till the time where the first prescription was initiated. These include demographic characteristics, the type of index VTE event, so was it a pulmonary embolism versus a DVT, as well as whether that VTE episode was provoked by certain clinical factors. Is it provoked by the fact that you've had a recent hospitalization or major surgery or major trauma in the 90 days before that event? That would be considered as transient provoked. We also had a definition for persistent provoked, which mostly included individuals with active cancer. And we also had ones that did not fall in the first two buckets that I mentioned were considered as unprovoked in our study. Then we have other variables such as some lifestyle factors, history of bleeding, and a Hasbled score, cardiovascular comorbidities, liver and renal disease, some prescription medications, mostly cardiovascular, as well as estrogen and progestin use, and utilization of healthcare services. The analysis that we performed to adjust for confounding was propensity score matching weights. So this represents an extension of the inverse probability of treatment weights that's already pretty popular in the literature, and it standardizes the distribution of the covariates to those which have an empirical equipoise. So in this case, when we have three different groups that we want to compare as a head-to-head, it weights the population to one that would be eligible to be prescribed any of the three medications. So we first fit a multinomial logistic regression model to predict patients' probabilities of receiving any of these three treatments. Then we calculated the weights using the formula given here, which is just whatever is the smallest propensity score for any of the three drugs divided by the propensity score for the treatment that they actually received, which is the same denominator for the IPTW. We estimated hazard ratios and 95% confidence intervals using weighted Cox proportional hazards regression with robust standard errors. And we were also really interested in certain subgroups just to get an idea of like if one of the subgroups, if one of the drugs might be more beneficial or more harmful in one of the subgroups. We performed our primary analysis, which was the on-treatment. The follow-up for these for the individuals in this analysis started the day after the oral anticoagulant initiation till the first occurrence of any of the following. So outcome, treatment discontinuation or switching, loss of medical and or pharmacy benefits, death, and end of the available data, which was 31st December 2019 for Market Scan and Medicare, and 31st December 2020 for Optum. Secondary analysis, we performed the intention to treat analysis with a fixed follow-up of a year. And the follow-up for this just did not include switching or discontinuation as a censoring criteria. So in terms of results, we included about 190,000 individuals fulfilled our selection criteria, of which you can see that majority included apixaban, followed by warfarin, and then rivaroxaban. Apixaban really took off after the introduction. So in terms of the patient characteristics, they were largely pretty similar to each other, but we did observe certain differences. So for example, we noticed that there were certain conditions which were a lot more common in individuals who had warfarin or apixaban, such as, so chronic kidney disease, as well as atrial fibrillation. And we, surprisingly, we did notice that those who had a prior hospitalization for one of the major bleeding events, not necessarily in the primary position, they were more, the percentages favored those who were initiating warfarin. So in terms of the results, I'm just going to describe this table because it looks very blue. So the top, if you look at the table, what I have here is the number of events along with the incidence rate per 1,000 person years, as well as the hazard ratio and the 95% confidence interval on the right side. So the top part is the unweighted analyses, and the bottom one is the weighted analyses. So I'm just going to focus on the weighted part, just so you know where I'm going with that. So in terms of the hazard ratio, as evidenced as even published in RCTs, we did note that apixaban performed a lot better compared to warfarin with a hazard ratio of 0.7, confidence interval of 0.63 to 0.78. Rivaroxaban was also considered more effective than warfarin. And we also, because it was a three-way comparison, we were able to get an estimate of apixaban versus rivaroxaban as well. And we did note that apixaban compared to rivaroxaban also performed much better. In terms of major bleeding, we found results which support at least the apixaban versus rivaroxaban kind of comparison, which was apixaban was associated with much lower risk of bleeding as compared to warfarin. In terms of the rivaroxaban and warfarin combination, we did notice that we've observed a slight increased risk with one of our definitions. We're still investigating that to see what's happening over there. For the secondary intention to treat analysis, it matches up with what we observed in the primary on treatment, except for we did notice that the increased risk of major bleeding that was seen with rivaroxaban compared to warfarin was not really observed here. So some strengths of our study is we had 3 US healthcare databases. We implemented a type of matching weight, which allowed us to look at a population that could be prescribed any of these 3 populations. And we also tried to use validated definitions. In terms of limitations, we potentially have unmeasured confounding, especially in terms of frailty, because we did observe a large increased risk of bleeding with older individuals. Certain data considerations, just because we have insurance claims data, and we have dispensing instead of prescription information. In conclusion, we concluded that patients with VTE who initiated apixaban had markedly lower rates of VTE recurrence and major bleeding compared to rivaroxaban as well as warfarin, which was consistent throughout all the subgroups. I haven't shown the subgroups here, but I do have it as a supplement. We also observed a smaller reduction of risk of recurrence of VTE with rivaroxaban compared to warfarin, but in terms of the results of bleeding, we're still working out. We are seeing a slight increase to a null effect. So overall, apixaban appears to provide a better overall risk-benefit balance than either rivaroxaban or warfarin in these populations. This is I would like to acknowledge my group as well as Josh Gagney, who helped a lot in the design and the analysis phase. Thank you so much.
Thanks, Gisa. We have time for a few questions.
Doug Watson, retired from industry. So you said that patients who hadn't refilled their prescription within 14 days after the end of day supply were considered discontinued. So they weren't included in your first analysis after that discontinuation date,
Yes.
correct?
So
If they had an outcome during that 2-week period between the end of days and when they were discontinued, was that outcome included?
That was counted, yes.
Okay. And if one of those patients who was considered discontinued then subsequently refilled their prescription, but after the 2-week period, they were not included in the first analysis, but were included in the intent to treat analysis.
Exactly,
Is
yes.
that correct?
Yes,
Okay.
thank you.
Hi, Bennett Levitan from Janssen. So one of the things I've observed with the newer anticoagulants is that they differ quite a bit in how they handle the more severe bleeds, like fatal bleeds and critical organ bleeds, versus the transfusions and hemoglobin drops. In fact, compared to warfarin, some of these will protect against the more severe bleeds, but cause more of the less impactful ones. Are you able to dissect your data to that level instead of just looking at major bleeding as a whole?
So I feel like the max we could try and dissect the situation would be to look at potentially only primary position, like try and see whether the positioning of the diagnosis matters a lot, because at least in the Cunningham definition, it was always accompanied as the bleeding code had to be in some type of bleeding code has to be in the primary position, with supporting evidence potentially with either a secondary or any position diagnosis. So I feel like that is a possibility versus what Edward also said, that using blood transfusion as a way of assessing severity of bleeding, that's a great idea as well. But in this case, we tried to include those bleeding codes which signified, at least from the way that the code read, a major bleeding. So we did not include individuals who had epistaxis or hemoptysis and things like that, which you could have uncontrolled hemoptysis, obviously, but largely that is not considered a very severe.
Right, those would be
event.
non-major clinically relevant
exactly,
rather than
yeah.
major. Yeah, so I guess the upshot is it can get misleading if you're causing a lot of the less impactful bleeds, but preventing the more serious bleeds. But these databases aren't giving you the fidelity to take that apart. Thank you.
Thank you.
Thank you. So our final presenter is Xinyi Huang.
So this one, and okay. Hi, it's me again, Xinyi Huang from National Taiwan University, and I'm really lucky to have the second chance, twice chances to stand on this stage in the same section. So in this part of my presentation, I'm going to introduce our study regarding the effectiveness and safety of reduced dose prasugrel versus standard dose ticagrelor in an East Asian population with acute coronary syndrome following undergoing the percutaneous coronary intervention. This research was supported by the following sources: National Taiwan University Hospital and National Science and Technology Council of Taiwan, and the authors had no conflict of interest to the study's content. Standard dose prasugrel with the maintenance dose 10 mg per day is a guidelines recommended dose for acute coronary syndrome patients. However, previous studies have found that the Asian populations may have a higher prasugrel serum level and also a higher platelet activity inhibitions compared to the Western countries' patients. Therefore, the reduced dose prasugrel with the maintenance dose 3.75 mg per day was approved in Taiwan and Japan, and it is also the only approval dose in Taiwan. This dose was approved because of the clinical trial results from the Japanese population, and they found that the reduced dose prasugrel provides a similar efficacy and safety profile to the clopidogrel users. However, regarding the two potent new generation P2Y12 inhibitors, prasugrel and ticagrelor, the evidence is still limited regarding whether the reduced dose prasugrel is as effective as safe as the standard dose ticagrelor in the real-world clinical settings. So this study is going to evaluate the effectiveness and safety of reduced dose prasugrel versus standard dose ticagrelor in patients with acute coronary syndrome, which is ACS, undergoing percutaneous coronary intervention. The study uses the full population data of the Health and Welfare Database in Taiwan. Data from 2017 to 2020 was used as the data source. This was a retrospective cohort study. We included the patients which had a first ACS hospitalization between 2018 to 2020 and were discharged with dual antiplatelet therapy, prasugrel plus aspirin, or ticagrelor plus aspirin. And the first ACS hospitalization was defined as the index ACS, and the discharge date of the index ACS was defined as the index date. Patients were followed from the index date to the earliest occurrence of the following events, including the outcome of interest, stop using dual antiplatelet therapy, death, or until December 31st, 2020. And each of the patients in this study was assigned a maximum 9-month follow-up period. Patients were excluded if they had a history of ACS, intracranial hemorrhage, ischemic stroke, or transient ischemic attack, or underwent PCI or CABG within 1 year prior to the index ACS. And patients were also excluded if they were under 20 years old, received CABG, fibrinolytic therapy, or died during index ACS admission period. This study divided the patients into two study groups, exposure group and the reference group, depends on their first dual antiplatelet therapy after index ACS. And the patients that prescribed with reduced dose prasugrel plus aspirin were in the exposure group, and the patients that prescribed with standard dose ticagrelor plus aspirin were in the reference group. The effectiveness and safety outcomes were followed separately during the follow-up period. The primary effectiveness outcome was the composite of cardiovascular death, acute myocardial infarction, stroke, transient ischemic attack, and revascularization. And the secondary effectiveness outcome was each component of primary effectiveness outcome. And the primary safety outcomes was the composite of intracranial hemorrhage and major gastrointestinal bleeding. And the secondary safety outcome was each component of the primary safety outcome. Social demographics and the index ACS disease severity during the index ACS were adjusted as the baseline covariates. The comorbidities within 1 year prior to the index ACS and the long-term medications that used within 1 year prior to the index ACS were also adjusted as the baseline covariates. we applied the stabilized inverse probability of treatment weighting to balance the covariance between the two study groups, and the absolute standardized mean differences were used to assess the balances between the baseline covariance. And the Cox proportional hazard models were used to assess the hazard ratios of the effectiveness and safety outcomes between the exposure and reference. And in addition to the main analysis, we also performed subgroup analysis for patients who were over or under 65 years old, and for patients who were diagnosed with chronic kidney disease or not, and for the patients with different types of ACS. After inclusion and exclusion criteria, we identified about 24,000 of eligible ACS patients, with about 1,400 of reduced dose prasugrel users and about 23,000 of standard dose ticagrelor users. And before stabilized inverse probability of treatment weighting, we found that the prasugrel users were generally older, had more use in proton pump inhibitors, and with less use in heparin compared to the ticagrelor users. And after stabilized inverse probability of treatment weighting, the baseline covariates were all balanced between the two study groups. In this study, the two study groups each had about 3 months of mean follow-up period. And we found that in the results of the study, there were no significant differences in the risk of primary effectiveness outcome and primary safety outcome between the reduced dose prasugrel and the standard dose ticagrelor users. And regarding the subgroup analysis outcome, we found that the findings in the primary effectiveness outcome and the primary safety outcome were consistent to the findings of the main analysis. Only the patients with age under 65 years old showed a marginally decrease in the risk of primary effectiveness outcome in the use of reduced dose prasugrel. So regarding the clinical implications of this study, the study's finding can help the healthcare providers to prescribe reduced dose prasugrel to Asians, because previous study have found that the East Asians population might have a higher bleeding risk and also a lower thrombotic risk when using the antiplatelets. So the physicians in Taiwan usually prescribe patients with a lower dose antiplatelets for patients to prevent secondary thrombotic events. However, there's also concerns about the decreased effectiveness and the treatment failure associated with this lower dose antiplatelet use. So this study results can alleviate the concerns about the potential treatment failure associated with the reduced dose prasugrel use in Asians population. And we also acknowledge that this study may have some limitations. First of all, because the study had a relatively short follow-up period with an average 3 months of the follow-up period. And the second is that we're not able to assess the severity of the bleeding in the database we used for the study. And the third is that we did not directly compare the reduced dose prasugrel to standard dose prasugrel, because standard dose prasugrel is not available in Taiwan's clinical settings. So the conclusion of the study is that the reduced dose prasugrel can provide a similar effectiveness and safety profile as standard dose ticagrelor in an East Asian population. However, future study can directly compare the reduced dose prasugrel to the standard dose prasugrel to further confirm the results of our study. And I would like to thank to the co-authors of the study, Professor Zhizhen Wang from National Taiwan University, Ms. Yizhen Wu, a cardiology pharmacy specialist from National Taiwan University Hospital, and Mr. Zhenzhi Wu, a critical care pharmacy specialist from National Taiwan University Hospital. And I would also like to thank Ms. Linya Huang for her support with data analysis. So this is the end of my presentations. Thank you so much for listening.
We still have some time for questions.
Kate Bykov from Harvard. Great talk. Thank you so much. I have a couple of really short questions. So I might have missed it, but how did you censor people during follow-up, or what type of analysis did you do?
Yeah. Thank you for this question. So we censor the patients if they switch or discontinue to discontinue the original dual antiplatelet therapy, or if the patients that the outcomes were occurred, and or if the patients that were found dead or until the end of the administrative period. So in this study, in the main analysis, we do the as-treated analysis. So we censor the patients if they happened a certain occurrence of the events that we defined. And additionally, we actually did a sensitivity analysis by the intention to treat approach, that we did not censor the patients if they switched to another antiplatelets or they discontinued the original antiplatelets. So both of the results shows consistent to each other. Yes.
Okay, perfect, thank you. And then the second question is on aspirin. So I'm not sure about your data, like in the United States, we don't see a lot of aspirin because people can just buy it from the pharmacy. Like, so how does it work in your data, and how did you ensure that patients in both group had equal exposure to aspirin at baseline and I guess also during follow-up?
Yeah, that's a very great question. So because in Taiwan, we can access to the healthcare very easily. So all of the medications, if we go to the outpatient clinic or from the local medical doctor, they can get reimbursed from the National Health Insurance Program. So most of the patients will receive their medication, especially the chronic medication treatment from the outpatient visits, from the physician's prescription, so that they can actually get the reimbursement from the insurance. So if they get the medications from the pharmacy, they need to pay by their pocket. So we are pretty sure that in the data we use, the patients that prescribe with aspirin is most of the patients in Taiwan will look like that. But there might be some part of the patients that bought the aspirin by themselves from the pharmacy, but these patients will not be included in our study.
Okay, perfect.
Yes.
Thank you.
Thank you.
Thank you very much. Yehua Wang from University of Florida. I have questions regarding, so in the previous head-to-head comparison of prasugrel and ticagrelor in the randomized control trial, so people have so the treatment persistency of ticagrelor is much shorter than the prasugrel. And I'm also wondering, in your research setting, what does that look like? And also, because from economic perspective, people sometimes have concern regarding the affordability of the drug price. For example, ticagrelor is like higher than prasugrel, especially now prasugrel has its generic version entering the market since 2017 in US market. But have you whether you have take a chance to look at their house economic affordability in your analysis, or it's similar in Taiwan? Thank you.
Thank you for your question. So for the first questions, we actually did a switch descriptive analysis in our study, and we found that the patients that receive ticagrelor are more likely to switch to another P2Y12 inhibitors. And the prasugrel users are more likely to stay in their original treatment. So the reasons we mentioned is that probably the patients that receive the ticagrelor treatment are more likely to develop the adverse event, not only the major bleeding or that the adverse event that is very serious, but also some very minor adverse event, but very annoying adverse event. So they will be discontinued, the original treatment of the ticagrelor. So in Taiwan, we see that also in our database. Yes, and for the second question is that because in the Taiwan, when they prescribe the medications from the physician's prescription, they can get the reimbursement of about 90% from the National Health Insurance Program. So in Taiwan, the physicians and both physicians and patients will not care much about the money, but only the payer aspect, they will care about them. So the approval of the medications in Taiwan will be very restrict, and the reimbursement criteria will be stricter than the US. Yes.
Thank you.
Yeah, thank you.
Great timing. So thanks to all the presenters for such a great session, and thanks for attending. This is the end of this session.
Yeah, I hope you enjoy the rest of the conference.
Yeah.
Thanks for coming.